All right. One of the last points I made last class was about how vasoconstriction of the arterial basically really increases resistance. That peripheral resistance, PR or R, is inversely proportional to the radius, lowercase r, to the fourth power. And now we're going to learn how the body, this occurs in the body to control blood pressure and blood flow. You have a localized way and a widespread way. The localized way intrinsic mechanism to control blood flow. That's what I'm writing here. So pretend you have an like I give you that picture there, right? And then they show a little arterial coming off a larger one. It has a certain amount of blood flow, call it F, and it's feeding a capillary vein. And these blood vessels, these arterioles, they auto-regulate themselves. They control blood flow based on the tissue's needs. So you had some cells of the peripheral tissue that need oxygen, of course. And your book lists all kinds of metabolic molecules that kind of self-regulate the flow. All you want to do is make sure there's enough O2. Okay. Sometimes these vessels constrict and they turn off the blood flow, like this picture here. So when they constrict, they usually kind of clamp down. You decrease the radius and increase the resistance to blood flow. So you reduce flow. Okay? If you have plenty of O2. Now you can't always kind of turn off the blood flow. What happens is, if O2 levels get low, the word for that is hypoxia. Hypoxia, hypoxia. Something that'll happen is the endothelium will produce nitric oxide. NO, I've mentioned that before. Nitric oxide affects all blood vessels. And I'll give you those two metabolic molecules to pay attention to. Hypoxia causes an increase in nitric oxide. Nitric oxide is a vasodilator. I'll put VD for vasodilation. So it'll basically reverse what I wrote. So you'll vasodilate, you'll increase the radius, you'll decrease the resistance to blood flow, and you'll increase flow. Okay, so you'll just go back and forth between constriction and dilation to just self-regulate constriction dilation to prevent hypoxia. So that's what I'm writing, self-regulate the vasoconstriction, VC, vasodilation, to prevent hypoxia. I say hypoxia, it's a different way of saying ischemia. To be technical, hypoxia is a lack of oxygen. Ischemia is a lack of blood flow. And, well, a lack of blood flow was the same thing as a lack of oxygen, because that's what the blood brings. All right, that ischemia is a lack of blood. I forget if it's Greek or Latin, but the word root hemia means blood. The other mechanism I'll talk about more because it's a systemic response. It's actually the basis of our lab on Friday. Let's see here. So the second mechanism is not localized. It's actually widespread. It's systemic, and it involves sympathetic innervation. Widespread extrinsic sympathetic mechanism to basically increase blood pressure. And this is not new information. I taught the concept last time. Let me just jump back a slide to remind you of that point when I taught this slide. Sorry. Yeah. When a sympathetic nerve just innervates the tunica media, like this, you get vasoconstriction, it causes blood pressure. So that's what I'm talking about now, but I'm going to include some more details. So think about the things that cause a fight or flight response. One of the common things is what they call a noxious stimulus, pain. I don't know if I mentioned this yet, the cold pressure test. It's one of the tests you're going to do on Friday, one of your subjects. If you subject the subject to pain, it triggers this sympathetic response. And we're going to study the reflex that kind of controls it. But as soon as you experience pain, everything gets pumping. The cardiovascular system kicks in and you should observe an increase in blood pressure. So here's what happens. So I'm going to draw a few more of these little blood vessels here. So let me draw one, two, let me draw a third one, and then let me draw one down here. Okay. This is a systemic response. I want to draw more than one. So what happens is, so these are arterioles. Arteries are arterioles. Sympathetic innervation innervates, say, these top three. In a sympathetic response, what it does is you use those sphincters and you clamp down on one location to vasoconstrict. So let's say these three vessels are vasoconstricted. You just kind of really restrict the blood flow past them. Like that. You just kind of squeeze it. So you really, here you're increasing the resistance to blood flow by vasoconstriction, which is always a decrease in the radius of the vessel. Okay. And so this happens very well to organ systems that you don't need in a fight or flight response, like the GI tract and the liver, which are for digestion. So this happens well at GI and liver. So let me get these terms, let me put them up here. So they're out of the way. Decrease radius, lowercase r, increase overall peripheral resistance, big R. Okay, so what you're doing is, by vasoconstricting, by decreasing the radius, VC, vasoconstrict, you keep more blood in the arteries. Blood is trying to flow out of here in the GI and in the liver, but it can't because there's increased resistance. So you get more blood stays in the arterial system, and you observe an increase in BP. So when your subject is doing the cold pressure test, you're supposed to take a blood pressure measurement every minute. So after the first minute, you should see an increase in BP compared to baseline before they submerge their hand and are subjected to pain. Now the reason for keeping more blood in the arterial system, you want to shunt it to where you need the blood, the working muscles. So there's a small group of arterioles that actually vasodilates. So I'll just draw it bigger, right? I'll put VD. It's a smaller group, just the arterioles that are supplying blood to skeletal muscles. You know, the ones that you're using, run or fight, whatever it is, but the point is you vasodilate, you don't vasoconstrict. Ultimately, you're increasing the blood flow to there. So you're just shifting the blood flow from one place to another, and overall you have an increase in blood pressure. Because everything else is elevated too, heart rate, and you'll see all that. Okay, so that's just the arteries. What about the veins? So pretend you have a big capillary bed here. Then you have your big veins that are a collection and return system. The sympathetics affect them too. In fact, they affect them over a wider area. For veins, you shrink the whole system just a little bit. You don't clamp down like in one place like here. So maybe the whole thing is just, the whole container shrinks just a little bit. For veins, you have a slight reduction in radius. And usually the rule is you decrease radius, you increase resistance. However, you don't want to do that. But because you're affecting it differently, this slight decrease in resistance, it has no effect on resistance. This slight decrease in radius has no effect on resistance. So slight decrease there, no effect on capital R. Okay. I remember even as a student I was confused about this. I was studying and I was like, oh, okay, I got this rule memorized, right? That's what we do, memorize rules. And when the rule doesn't make sense, we get confused. I said, okay, you decrease the radius, you increase resistance, you decrease flow. And the professor says, oh, in this case, you don't affect R. So I remember going to opposite hours, right? I thought that was the rule. It doesn't work for veins. What happens is, it's like if you, this is what he told me, he's like, okay, it's like when you take a garden hose. Imagine in the garden hose, you turn the water on, and you just crush the garden hose at one place. You stop the flow of water. I was like, yeah, okay. Imagine just taking the garden hose, but instead of just clamping down at one place, you just reduce the caliber just a little bit. Now, does that stop the water from flowing? No, actually, it would increase it, right? That's what's happening here. You're taking the whole garden hose and just shrinking it a little. You don't really affect the resistance to flow. What you do is you're more affecting the capacitance. Decrease capacitance. So I'll use a C for capacitance. 0.4. And when you do that, you're shrinking the whole container. You're really increasing the venous pressures. Ultimately, you increase the venous return. And you know the more in, more out law, Frank started the law of the heart. That law says if you increase venous return, you increase cardiac output, right? And that's really the end result of what you want to do. You want to increase the cardiac output. You want to, I'll box it up here, my notes are all over the place. The things I boxed are the ultimate goals of what you need to understand as a student, okay? Because we're going to look at an equation that says, basically blood pressure is a product of, cardiac output and the peripheral resistance, okay? So if you want to maintain or increase the BP, you have to increase the cardiac output and increase the peripheral resistance. That will help increase the blood pressure. That's what's happening. When you measure an increase in blood pressure, you affect the arteries, you affect the veins too. Okay? Both kinds of blood vessels there. Okay, any questions on how you affect the arteries, how you affect the veins? You really affect the vasoconstriction at one location. You slightly affect the vasoconstriction over a wider area. It's different. So that's kind of what I say here. The sympathetic input, there's a vasoconstrictor response very well at the GI tract and liver. Okay, that's this part. There's sympathetic inputs to the working skeletal muscle beds that has a vasodilator response. So that's what I did here. Okay. You get the blood going to where it's needed for your sympathetic response. So the other thing I said, in terms of the veins, venules and small veins, you increase the venous return. There's a term for all of this that I wrote on the board. It's called the mobilization of the blood reservoir. And let's remember that's where all your blood is sitting most of the time, 60% of it. The sympathetic response, you mobilize it and you get it to the other side. So if you want to title this, call it mobilization of the blood reservoir. So let me read what I have on the slide. It should reflect what I wrote over here. The sympathetic stimulation to the venules and small veins generates a small constriction over a large cross-sectional area. So paraphrase what I said over there. I said slight decrease in little r, right? No effect on big R. The change in radius affects capacitance, right? Not resistance. Change in radius affects capacitance, venules and small veins with no effect on resistance to flow. Changes in capacitance rather than resistance occur because a larger cross-sectional area is affected. So I just want students to know, sometimes books don't mention that. Most books will mention that you affect the artery side, but they don't mention how you affect the vein side. And you should know both. And so, start to sum up here, these slides. I have 1, 2, 3, and 4. Basically, the 1, 2, and the 3 causes number 4, maintaining mean arterial blood pressure. Number 1, inflow, outflow, we talked about that, okay? The blood pressure is largely determined by controlling the inflow and outflow into the arteries. But now we learn this 3rd thing. You can vasoconstrict slightly increase the venous return. That will increase the cardiac output. So all three of those things are basically this equation here. Okay, so really what I'm trying to get you to think is cardiac output and the resistance, they will always increase together to increase the blood pressure. That's how you have to think. And you'll never go wrong, at least for this test.
That will also increase the RV pressure too.
Say it again?
That will also increase the RV pressure.
Say it one more time, I can't understand you.
The venous pressure will increase the RV pressure, like
the venous pressure will increase the venous return.
But it will not increase the RV pressure.
The RV pressure?
Yeah.
No. What will happen to the RV is it'll just increase its cardiac output.
Oh.
And then the left ventricle will increase its cardiac output. Ultimately, what I want you to know with that is you increase cardiac output, more in, more out. So in terms of breaking it down in an outline form, this equation here, okay, as a student, physiology is how does the body work? Here's how it works. You can control cardiac output by understanding how heart rate and stroke volume are changed. If those increase, cardiac output increases, blood pressure increases. You need to understand how you control the outflow, the peripheral resistance, okay, by controlling the vessel radius by either constricting or dilating. If you constrict, you increase resistance, and that increases blood pressure. And the increases always go hand in hand. Okay, it's not like you do one and not the other. Okay, blood pressure. So that's the thing you control. So the 1 and the 2 control 3. So it's really understanding these bullet points here is how you control blood pressure. I think that's about as simplified as I can make it. All right, so mean arterial pressure is important. And your book does spend some time talking about venous pressures because when you're not sympathetically stimulated, there's hardly any venous pressure. And we have to kind of figure out, well, the veins are so far away from the heart's not helping generate pressure there. How do veins get the blood back to the heart? The venous system must overcome very low pressure gradients to accomplish venous return to the heart. And I have a list of a few things here, and they're kind of modifications to maintain venous return. What is this? So the basic idea is veins are too far away from the heart for it to be an effective pump for veins. So what is pumping blood in the veins? They don't have the heart. Here are some modifications that help it deal with this conundrum that the veins are in. Let's see here. Okay, number 1, large lumens. How do you overcome this? 1, so, how do veins accomplish venous return without without help from the heart. I'll frame it in the form of a question, and here's the answer. 1, large lumens. What we learned is if you have large lumens, you have decreased resistance to blood flow. Okay, you have more laminar flow. That's one thing. The other thing are the venous valves I mentioned earlier. Arteries only have that one valve at the very beginning, the aortic valve. After that, they don't need it. But veins need valves throughout their length. Because at the very least, when the valves close, they'll prevent backwards flow of blood, as shown in the picture on the right. So imagine you're standing upright, maybe you're a factory worker and you stand still all day and this is what you got. But you don't want to do that. You want to walk around and help circulation. Varicose veins are a failure of the venous valves. Okay? Ultimately, you don't want it just kind of standing in a still column. You want to squeeze this blood back up to the heart. So in conjunction with skeletal muscles, you can accomplish that. So instead of the heart being the pump, they call this the skeletal muscle pump. So in conjunction with the valves, when muscles squeeze veins, they help the venous return. Working with venous valves, the muscles contract and squeeze veins. When muscles contract, they squeeze veins to help venous return. I mean, think about this vein as having compartments since it's got the valves. Call it top, middle, bottom. Okay? So when you squeeze the middle compartment, the blood is squeezed in both directions, but the valve on the bottom closes, preventing backwards flow of blood down on this bottom compartment. So blood in the middle compartment is squeezed into the top compartment back towards the heart. Okay? Because if you didn't have the valves, and you just squeeze a tube full of fluid, you just squeeze in both directions. But that doesn't really help venous return because you're only moving half of the blood in one direction, right? So it helps to squeeze it all in this direction there. So that's the skeletal muscle pump. Okay? Your muscles are your pump for your veins, not the heart. Now, you know, a long plane ride, it helps to walk around, right? Because the muscles are not contracting very much when you're in a seated position. Oh, here's the same thing. It's just a different slide showing the same concept. Let me move on. You have another pump called the respiratory pump. Okay? And they show a person lying supine, and here's the heart beating in the chest. Because of respiratory activity in the chest cavity, that just means when you breathe in, doesn't your chest expand a little bit? That's what we're talking about. We call it increased thoracic volume. Whenever you increase the volume of anything, you decrease the pressure inside. So, because of that respiratory activity in the chest cavity, pressure surrounding chest veins is lower then pressure surrounding veins and extremities and abdomen. This establishes a pressure gradient that drives blood towards the heart. So they show you, well, basically the pressure of the atmosphere, right? We live under 1 atmosphere of air, okay? After that is outer space. But anyways, you don't perceive it, okay? But anyways, the atmospheric pressure is less in the chest. So that creates a slight gradient to get blood back there. And notice how it only really works when you're lying down, right? So you eliminate the hydrostatic pressure, okay? So this is why, if you're stressed out, and lay down and relax, you help the respiratory part. So I'll add it to my list of 3. I guess let's make it 4. Pressure surrounding chest veins. Is slightly less than pressure in the extremities. Slightly less than pressures in veins of the extremities, however you want to put it. Let's remember the rule, blood always flows from the area of higher pressure to lower pressure, okay? Remember, for this one to really work, you gotta lie down to eliminate hydrostatic pressure so you're not fighting gravity, because that gradient's not very steep. I did have some practice questions, but they're for practice, they're not for lecture. So if you need a review, I know I have my study guide, but it's good to go through these. Maybe I'll go through them too when I write my next quiz. Hint, hint. So it might be good to look at, eh? All those to the end. So practice questions finish off those slides. The next batch of slides covers the baroreceptor reflex, which I'll start now. The baroreceptor reflex, that is the basis of our lab on Friday. Friday's a mandatory lab, don't miss that lab. If you have experience taking blood pressure measurements using a BP cuff, you'll be a real help to your lab. You can even be the teacher for that day and help your lab mates learn how to do it well, take a good reading. There also, if you looked at the procedures, is a part where you're going to compare 2 people exercising. And so look in your group and ask, hey, can you 2 exercise? Come dressed appropriately. So I want to mention that. There's also a part of the lab where you got to lie down. So it might be a good idea to bring those exercise mats again. Okay? So I wanted to mention that so you're prepared for lab. All right, I want to start off, this is basically how the blood pressure is regulated by the body. I want to show you what happens when things go wrong, hemorrhagic shock. Hemorrhage is bleeding. Here's some data. looking at here, it says percentage of blood removed. That's a very, very sterile way of saying you're bleeding to death. Hemorrhagic shock. Sometimes I want books just to shout to students, this is a bad thing. But we know we have to study academically, so kind of look at it objectively. You're removing blood from the body, and look what they pay attention to. Cardiac output and arterial pressure. Okay, that is what is monitored. The arterial pressure is a vital sign of life. So hemorrhagic shock is the most common form of shock. Shock is lack of blood flow for a number of reasons. Number one reason is losing blood. The average blood volume is about 5 liters, and that sustains your blood pressure. When pressure starts to drop, that's when you get really concerned. And this data really highlights the value of the sympathetic reflexes I just talked about. Let me turn this down a little bit. Speaker's a little echoey. And this is the time course of 100% remove is about a half an hour. Okay, so think about this. That only takes a half an hour to lose all my blood. How long does it take first responders to get there?
10, 15 minutes.
Oh, yeah, go ahead. Yeah, so it's like, let's hope that they can get there before that, when it starts to drop, right? Okay. So about, I don't know, a third of this time, about 10 minutes, depending on how bad the bleeding is. But, oh,
So sorry.
we're locked down. We're locked in out
You
again.
can go out around if you want.
That's okay.
I apologize.
No, it's okay. They don't care. You guys know who this guy is? Who is this guy?
Professor
Exactly.
Slatsky.
Exactly.
Oh, of course, my key's not
Worst
working.
of all of the A&D instructors.
Oh, there it goes.
Thank you very
Give
much.
yourself some credit, buddy. All right, so back to the losing blood lecture. Yeah, so highlights. The value of sympathetic reflexes. Okay, and what are those? Again, let's kind of get it down. 3 things, these sympathetic reflexes. Number 1, person who's in shock and you're trying to keep the blood pressure up, you'll notice a max out of the heart rate. Something like 180. A rapid pulse. Just trying to keep that cardiac output up in the face of loss of blood volume. The other thing is that vasoconstriction of the arterioles. You're really just trying to increase that peripheral resistance, capital R, to keep blood in the arteries so that that blood can be pumped to the vital organs. Okay, 3, that whole thing of the slight VC of the veins, right? Decreased capacitance, capital C, of venules and the small veins. Right, ultimately I said that increases the venous return. It helps to increase the CO, the cardiac output. Those 3 things. All those things are the sympathetic reflexes. And these effectively help keep arterial pressure elevated despite a 20% loss of blood. It's amazing. You can lose 20% of your blood and the body's able to keep pressure pressure elevated, even though cardiac output started to drop. Okay, but it's still staying elevated. They call this the first plateau. This first is kind of stable, it's high, with 20% loss of blood. So what's 20% of 5 liters? A liter. How much is a liter? 2 of these bottles. People always say, you've lost a lot of blood. I've always wondered, how much is a lot? Well, according to these data, 2 bottles of blood is a lot, because after that, your blood pressure starts to drop off.
So when we donate our blood,
Yeah.
how much blood we donate?
Any blood donors out there? 200 pint, yeah. This is 500 ml.
Yeah.
So, and you always want to get your blood backed up. Eat breakfast, drink some OJ after you get blood. But anyways, if you ever become a first responder and the person's bleeding, look at how much blood is in their clothes. Look at how much blood is on the ground, and try to just kind of they'll train you. I don't know. Yeah, I have my paramedic program. Sure. Okay, so. Keeps BP up. So note that first plateau. I'll call it MAP. Mean arterial pressure remains normal despite 20% blood loss. And then, of course, eventually blood pressure drops if you just lost too much blood. The thing you may not notice is a little blip there. I read about it and figured. This one here, at 40% blood loss, you see this little second plateau. During the first plateau, you're losing blood. What the body does with these sympathetic reflexes, you keep blood flowing to the vital organs, basically the heart, lungs, and the brain. Okay, but at 40% blood loss, we observe the second plateau. Because at 40% blood loss, the brain starts to become ischemic, and it's like super maxing out sympathetic reflexes in an effort to save itself. At 40% blood loss, brain becomes ischemic. It maxes out these sympathetic reflexes. Like a last-ditch effort to save itself. So your book teaches you very thoroughly how the body is able to maintain blood pressure normally, in the absence of pathology or a lot of blood loss. They basically categorize it into like short-term and long-term responses. Short-term responses are always reflexes. They happen really quick, instinctively, involuntarily, and we'll learn about one today. The longer-term responses we studied in the endocrine chapter, longer-term responses are hormonal that actually can help, in most cases, increase the blood volume, and that helps increase or maintain the blood pressure. So I'll focus on one reflex called the baroreceptor reflex, again, the basis of Friday's lab. That's why I'm doing it today, to get you ready for that. And longer term ones should be a review, because we talked about just about all the hormones that I want you to know that help increase the blood volume, increase the blood pressure, most of them. And so just to kind of get that part out of the way, I just put this slide together. It's like, okay, these are the ones they should go back and review for this exam, for the long-term controls. I'm writing hormones help regulate BP over the long term. Long term in this context, like hours, days, kind of a thing. Over the long term, by altering blood volume. Review slide, and in turn review whatever you got in your previous notes from that chapter, or just go to the book. To summarize here, if the imbalance is a drop or an increase, that's the imbalance. You always want to do the opposite as the response and result, this column here. So things in between are the hormones that do this. So we'll actually talk about epi and norepi today. Your catecholamines, epi, norepi, they basically will increase cardiac output, increase peripheral resistance. That helps increase BP. All the other ones alter the blood volume. If you have a jump in blood pressure, an increase, AMP, atrionatriuretic peptide, is one that will increase the water excretion to drop the blood volume and drop the blood pressure. These last three all increase it. If the disturbance is a drop in blood pressure, and we're studying ADH, right, antidiuretic hormone. Okay, go back and look at that. It helps increase the blood volume. EPO, I don't know if I mentioned that yet. That's short for erythropoietin. It comes from the kidney. The kidneys filter all of your blood, so it's a good place to recognize that fluid levels are down, right? So it secretes EPO. It targets the bone marrow, and it helps increase your CRIT, your red blood cells, and that helps increase the oncotic pressure, which is the same thing as that colloid osmotic pressure I taught last time. If there's more stuff in the blood vessels retain fluid better. Okay, so that helps to increase the blood volume and increase the blood pressure. And the last one is, remember the RAS mechanism, the whole renin thing? You're not done with that yet. So I put review in question mark as if you need to review it. I would say most of you do. There is a question on that. I won't make you write it out again, but I at least have a multiple choice question on it. It comes up again a third time. Guess what chapter? Kidney. Okay. So that one you're not going to get rid of easy. Might as well study it again. Okay, so those are the hormonal controls of how you can regulate blood pressure. Really quick on that because we did talk about that issue a lot in the endocrine chapter. Well, let's unpack what's called the baroreceptor reflex more. So this is a reflex. It's involuntary and they're much faster. They occur in the time course of, say, minutes, seconds, okay? And so this is where learning this equation comes into play. It's going to help us with this lecture. The things on the right side of the equation cause an increase or decrease in the blood pressure. Okay? It's never a change in blood pressure causes CO or RA change. It's always the other way around. You know, and I have you write about these things, and I look for that kind of reasoning. So just to remind you of what a reflex is, a reflex must include, all reflexes, some receptor that detects an error. In our case, it's going to be blood pressure. It's going to jump up or down. You need afferent pathways to convey the action potential signals away from the receptor to the central nervous system. You need a control center, okay? Some brain center function that compares the input, compares the action potential input to a set point. It processes it, gathers information, and you mobilize an appropriate efferent response. Okay, so you need the motor pathways. You need afferent pathways and efferent nervous pathways. And you need effectors, organs to affect, that will correct the homeostasis and restore your set point. And so what I did was I took that same outline for any generic reflex, and I just put in red all the things that are in this reflex that we're talking about, the baroreceptor reflex. And a reflex is a good one. It works in both directions. It can correct it if the blood pressure is too high, it can lower it. The other thing is, if the blood pressure is too low, you want to raise it. So we'll try to do both of those things in lab. And have you see how the reflex kicks in to correct it. Baroreceptor reflexes correct increases, or I should say and. Well, I don't know, and or, it doesn't matter. Decreases in BP. There's a good figure, kind of maps it all out for you. This one, okay? So let's go through it. And it's the classic Marieb teeter-totter homeostatic imbalance thing. Because if the little teeter-totter is level, you're at your set point. But if the imbalance is out of whack one way or the other, the reflex kicks in. So this imbalance is blood pressure is too high. Okay, the reflex corrects it. So let's go through that. I'll just follow the outline. So in lab, what we'll do is blood pressure too high. Okay. Now, I would say as a student, even for myself, I have to do this. If I tell you the imbalance, or if you know what the imbalance is, automatically in your head, just write down, okay, if that is the problem, the body needs to decrease blood pressure. And just write it down. That's what this reflex should do. So in lab, how we'll cause the imbalance is, again, the cold pressure test. Whenever you see the word pressor in physiology, it means an increase in blood pressure. Submerge the hand in cold water. It's a painful stimulus. Okay? The painful stimulus will basically turn off the parasympathetic. You kind of let the sympathetic go, and you see an increase in BP. So we'll call that number one. Number one is here, if you can't see, I'm so sorry. That's the stimulus. Painful stimulus in our lab. Okay, and because it's painful, you know, I always want to say in lab, you can't force anyone to do anything. It's strictly voluntary. Usually there's someone who's going home and wants to say, I want to try it. But someone has to step up in your group. Okay. Painful stimulus, turn off. Parasympathetic. Basically, you're removing the sympathetic block. You're just letting it go. And by the way, what I'm outlining now is the written part of your test. So don't ask me to post it. What is it going to be? I just told you. Right? And yeah, how are you going to be able to outline this? This is essentially everything we're talking about in the blood pressure chapter. Turn off the parasympathetic, remove the sympathetic block. The sympathetic is kicking in. When you excite the sympathetic, you're going to see that increase in BP, right, from the painful stimulus. That's it. So what's the detector? What's the receptor? Number two, it says baroreceptor. That's it. Now, look where they are. This one is, you have it in two locations, the carotid sinus and the aortic arch, really close to the heart, inside the vessel wall. what you should know about them is they're stretch sensitive and they detect changes in the transmural pressure. Detect changes in I'll abbreviate transmural pressure P-trans for short, so I don't have to keep writing it out. So stretch sensitive means, well, if you stretch the vessel wall, you're going to stretch it, and it's going to fire more, okay? So if you're having to jump in BP, what you're doing is you're increasing the P-trans, which means you're increasing the stretch in that wall. That baroreceptor is a mechanoreceptor. It'll mechanically fire more impulses to the brain. So if before, I guess unstretched, it's firing at some relaxed rate. Okay, if it's like you have a jump in BP because of the sympathetic nervous system, basically you get more APs, more action potentials. And you're going to send those signals to the brain. This is an afferent pathway. Okay. There is a cranial nerve that will do that. Okay, for number 3, it says impulses from baroreceptors stimulate all that stuff there in the medulla. Okay, so you should know that the impulses are carried by, I'll give you one nerve, cranial nerve 9, IX. Okay, those will carry the increased impulses to the brain. So that's number 3. The medulla is part of the brain we're talking about. Receives I'll say the increased APs, and that's the signal that will make your central nervous system respond appropriately. Okay, so the medulla, there's a particular center in there. So let me erase some of the top stuff here so I can start right around here. So 3 continued. Know that there is the cardiovascular center in the brain. I'll just call it CV center for short, cardiovascular center. It's part of the medulla. Okay. And that center, there's 3 subcenters I think we should talk about. Within the CV center, there is the cardioacceleratory center. There is the cardioinhibitory center. And the vasomotor center. Those 3. Write that down. So it's receiving the increased APs, and how does it respond? Well, I mean, I guess how you should think about it is, what do you want to do? Remember you wrote it down? This is where it really helps to write it down so you don't write about the wrong mechanism. Okay? You want to decrease it. So what will help us accomplish, the brain says, okay, what will accomplish a drop in BP? Well, you don't want to use the top one, right? You don't want to accelerate the heart. You want to slow it down. So let's see, don't use that one. Check mark. This is X. Use the cardioinhibitory center and use that one. Use this one. The nerve that it will use is vagus, cranial nerve 10. You use that one. That's going to be your efferent nerve to accomplish slowing the heart down. I'll get to that. Okay, third center. The vasomotor center, they control the blood vessels, and they're sympathetic. You don't want sympathetic to work here. Don't use this one. You want to minimize that. So when you turn down, it's like you're turning like a volume knob down. You're reducing the sympathetic tone. So that's what the brain is doing. It's like, okay, which centers do I use to correct the imbalance? And then so, you got arrows going from the brain to these organs. So you kind of have to know the nerves. Here's one nerve, the vagus nerve. The nerves that innervate the blood vessels are called vasomotor fibers. So it's easy. The nerves have the same name as the center. The fibers come from the vasomotor center. You're reducing them. So it's like you're turning down the signal in these vasomotor fibers. Emphasize the word reduce. So that's kind of what's happening. So at the fourth step, they have a 4A and a 4B. These are your effectors. These are the organs affected by this reflex. You got the heart. Because the vagus nerve is turning on there, you get more acetylcholine. Ultimately, you're going to have decreased cardiac output, decreased heart rate. Well, I should probably list things that cause the decreased cardiac output. I want you to think like that too. Okay, what you're going to have, decreased heart rate, decreased contractility, and those things cause a decrease in cardiac output. That's how you affect the heart in this reflex. The second thing they show is an artery. And what they're showing is vasodilation. I'll just put VD. When you vasodilate, you decrease the peripheral resistance. So ultimately, at the end of this logic here, you got that, and you got that underlined in red. Okay? And then so, I think after that is number 5. Number 5. So for number 5, always just relate it back to blood pressure equals cardiac output multiplied by capital R, peripheral resistance. And then look what you did at number 4. It should be down arrow, decreased resistance, decreased cardiac output, decreased blood pressure. Okay, and when you get to like number 5, always like, when you're studying, look back and make sure you did the right reflex. Okay, that's why I always write that down, even for myself. So, any questions on this reflex?
So the R31 vasodilate decrease R is the 4B?
Yeah.
Mm-hmm.
It's right here. Okay, so again, in lab, how are we triggering the imbalance? Cold ice water. Oh, it's where my daughter goes to this slumber party. Every year she does this test, except they don't do the hand, they do like feet. You see how long people can hold out. I guess it's fun, I don't know. But I never did that at a party. Okay, well anyways, you have one imbalance. It can go the other way. Blood pressure can get too low. So let's talk about this here. Gotta do both. other balance is if blood pressure is too low, you want to raise it. So in lab, what we do is we're gonna, you stand after having laid down for a few minutes. So it's standing after lying down to induce the drop in blood pressure. That's why I said bring the exercise mat, standing after lying down, supine. And that causes a transient drop in blood pressure called orthostatic hypotension. And that's the term to remember. Standing after lying down. That's the description. You know, when you're lying down, you're relaxed, parasympathetic is on, okay? When the parasympathetic is on, you're blocking the sympathetic, essentially. But then you're lying down, you know. Okay, so this is like happening when you like lie down, what is it? You lay down, relax, this is what happens. But then when you stand, the blood kind of goes to the ground. And your baroreceptors here and here, they detect a drop in blood pressure. Upon sitting or standing, blood pools in the extremities. So this is where we start our outline. Number one. You're going to have that drop in blood pressure right after you stand. I'll just put down arrow BP. Okay. Because the parasympathetic was on, you're blocking the sympathetic, but when you have a drop in blood pressure, that'll actually kick on a sympathetic response. So number two, baroreceptors. They're detecting a drop in P-trans. If you have a drop in blood pressure, you're having a drop in P-trans, the blood pressure is dropping, are you stretching it more or less? Less. Less stretch, less blood, less pressure. Okay? So that's intuitive. Remember, before, if you stretched it, it fired more. So if there's less stretch, you fire less. So if the rate of firing was, say, that normally, with less stretch, maybe it'll only be like that, to exaggerate, but less signal, okay? Less APs, basically. And that is the signal being sent to the brain, reduced impulses. Okay? Again, it's cranial nerve 9. It's still cranial nerve 9. So get down to number 3. I'll say less APs reach medulla. You still talk about the same centers we talked about before in the medulla, the cardiovascular center. So I'll continue 3 up here, number 3, medulla CV center. Let's remember, it's the cardio-inhibitory. Cardio-acceleratory. And vasomotor center. So if less APs are reaching the center, decrease APs, what is the signal this time? Now you take that information, what do I do with it? Again, look at what you wrote down. If blood pressure is too low, what do you want to do? Raise it, and just reason to yourself, okay, let's see, what was that? Well, I don't want to use the top one. Cardio, no, you don't want to slow the heart rate down. That'll just drop it more. X, don't use it. You do want to use these other two. You want to use the cardio-acceleratory and the vaso. You want to fire those more. Okay. So, in terms of nerves, the sympathetic efferents for the cardio-acceleratory, just remember where your heart is. It's in your chest. So that's about level T1 to T5, sympathetic efferents. Okay. So we're talking about spinal nerves, not vertebra. Okay. Level T1. T5 spinal nerve. They just call them cardiac nerves. You can call them that. They're sympathetic efferents. Okay, this is a sympathetic response. You're turning off the parasympathetic. You're removing the sympathetic block to boost your blood pressure, basically. So those are used. Now the vasomotor center, you're kind of turning down the volume knob before. Now you turn it up. You increase the sympathetic tone. To vasomotor fibers. I didn't mention this before, but in terms of sympathetic efferents, you have sympathetic efferents from T1 all the way down to the level of L2 spinal nerve. And you use them all, because blood vessels go everywhere. So T1 to L2, you use all levels. Every single level you got, you use the vasomotor fibers. And so what those do is you're going to affect the heart, the arteries, and the veins. So that's kind of like, they have 4A and B, but I added the veins as like a 4, call it a 4C. So 4A, you affect the heart. So you're going to increase heart rate, you're going to increase contractility, increase cardiac output. That's the end result there. Okay. In terms of the arteries, call it 4B. The sympathetic response from the vasomotor fibers, you're going to vasoconstrict. I'll just put VC, increased, capital R, right? That's the end result there. And then for the veins, what I had said this morning, where it's called a 4C, you have I'll put slight vasoconstriction, VC. You're not going to affect capital R. What you're going to do is you're going to decrease capacitance, increase venous return, increase cardiac output. That's the end result for that one. And I'll just write number 5 out here since I'm standing here. Blood pressure equals cardiac output times peripheral resistance. So now what have we done? You do all this work, right? Again, it comes down to, did you do the right thing? You want to increase BP, so you're yourself, okay, Yeah, I did. I did that. I did that. I did that. Okay, so I did it. Okay, so you increase that, and you increase the blood pressure. Step 5 is just a check. That's a good way to do it when you're learning this stuff, I think. Just go through the list. Don't forget anything. To unpack this a little more, I included some slides that kind of show you some data first with the baroreceptors. I think this study was done in dogs. The lines are action potentials. And so the data I pulled from, they had some set blood pressure, and they would step to different blood pressures. And when you step to a higher blood pressure, they observed an increased firing rate in the baroreceptor. Okay, that's what I was talking about, right? You either kind of stretch more, stretch less. Yeah. If you had to fill in the blank, they lined the vessel wall, but didn't I give you 2 locations, like here and here? What do you call the one in your neck? Yeah, that's the carotid, they call it the carotid sinus, technically, that's what it's called. The other one was kind of in the aortic arch. What would you put here? Now, there's a couple of things I would accept if this were a quiz. What do they respond to? I would either accept stretch, they respond to a change in stretch, or a change in transmural pressure. That's another way to say it. All right, here's a cranial nerve 9, glossopharyngeal nerve. You need to know that one. That's the afferent pathway. Okay, that's what we talked about there. Here's a picture of it. There's a picture of the carotid sinus right there. The carotid sinus is right at the branch point of the common carotid, where it branches into the external and internal carotid arteries. And there's a branch of it. It helps act as a baroreceptor, cranial nerve 9. So I just wanted to give you a picture of it. So the medulla, the cardiovascular center, we kept talking about those 3 subcenters, but here's the medulla. They do show some of the centers, right? On this picture, the purple is the parasympathetic vagus nerve, and here the green are the sympathetic efferents going to the heart. But I said today it was T1 to T5 for the heart. And I just did this one. This is a standard picture for the autonomic nervous system. They say C8 is the top sympathetic efferent. I usually read more. It starts at T1. T1 to L2, those are all the sympathetic efferents for the vasomotor fibers. Okay. All right. Let's see. You know, this is a good place to stop. I can pick it up here. What I want to do is I want to teach these slides right before the lab, because they pertain directly to the lab. So it's good to do it right before the lab. Remember to bring something to lay on. Talk about it with your subject who's going to exercise. And I'll see you Friday.